You're now live.
All right, here we are. We're back. Joint meeting, House Healthcare, Senate Health and Welfare. And the next topic on our agenda is on the utilization of telehealth. And we have some information report from the telehealth working group. And I'm going to just turn it over. Lauren, are you going to be the lead person on this?
I think so.
Okay, and so I'm just going to turn it over to you and let you go through. Are all the folks here on the working group?
Yes, in one way or another, these have been critical members of the working group.
Okay, so I'm going to turn it over to you, and we welcome the report.
Okay, well, thank you so much for having me in to testify. My name is Lauren Hibbert, Director of the Office of Professional Regulation. I'm going to do my best to share my screen. I did create a PowerPoint related to our work, but just at the foremost, this act required the facilitation of my office of a working group that had multiple stakeholders. The report lists everybody who participated in a meeting, or sometimes many of the people every single meeting. It was a massive amount of work over the course of months. The provider community, the associations, the health insurance community all really engaged in this work and gave a lot to the work. So a lot to be grateful for all of the stakeholders. Just as a sense of it, we had representatives of healthcare professions, including the boards. We had the executive director of the Board of Medical Practice, David Hurley, who was essential and very helpful. We had some folks from the Department of Mental Health. We had, of course, professional organizations representing healthcare. JESA in particular was really, really helpful throughout the course of this work. We had representatives of health insurers. Rebecca Copans is on today. She was really helpful bringing that insurer perspective, but we had other folks as well from both the state partners and the private insurers. We had interested stakeholders. We were receiving letters from all different areas of the healthcare industry and profession. We did hear quite a bit from the higher educational facilities, which was interesting. And I had not expected that at all. I had not even included them on the list of anticipated stakeholders, but they certainly became very evident that they were stakeholders. So it was really crucial work. And with that, I will do my best to share my screen. So as this PowerPoint shows, what we did was look at the landscape pre-COVID, when licensure was required, during COVID, when licensure was waived for the most part. And again, this goes back to our conversation earlier this morning with Act 91, Act 140, and then subsequently Act 6. And I should preface this is all related to telehealth, not deemed licensure, not expired professionals, not retirees. This is just telehealth. And then where we are now is this green bubble of post-COVID, although that's wildly optimistic. And that's the Act 21 of 2021 recommendations. So where should we go? And back to the previous conversation from this morning, what should become permanent in our statute that we've learned or that we've transformed how telehealth should operate in this state? The report was submitted on December 15th. It's listed under my name on the witness list today. It also is available in the reports section of the legislature. It's long. I certainly wouldn't have shared it with this group in this format, but I do recommend reading it. The working group had subgroups related to different ways to different solutions for telehealth. There's lots of models out there. There were, I think, 6 subgroups that met on a routine and continual basis to figure out which was the best fit for Vermont and for the Vermont consumer, for the Vermont provider, for the Vermont regulator. There was multiple factors that each solution was considered under, and the recommendations, I'm really proud to say, were unanimous, with some concerns raised, but pretty much addressed within the group. And just to give the Joint Committee some perspective, some of these meetings were 50 people were involved in this stakeholder engagement. It was really quite a feat, logistically, all virtually, but a lot of voices at the table, and I hope that most felt heard and that their perspective was engaged with and responded to. So that was the intent. So there's 2 sets of recommendations. One is a short-term recommendation, understanding that we're coming to the Act 6 cliff of the end of March of 2022. So the short-term recommendation would be effective from April of 2022 to June of 2023. And then there's a long-term recommendation that would be effective July 1st of 2023 for the foreseeable future. The short-term recommendation is a temporary registration. This balances the state's needs to understand who's here currently, and just to be clear, backing up, I think it's fair to represent, and it's certainly OPR's perspective, that if you're providing telehealth, you are practicing. Telehealth is practice. There is harm that can occur during telehealth, just like there is an in-person practice. There's benefit that can occur in telehealth, just like there is in-person practice. From OPR's perspective, we are reluctant to have different standards for telehealth than we do for in-person. The same standards of practice apply in both scenarios. The same ethical codes apply in both scenarios. And the same requirements of the state to be aware of who's practicing are in both scenarios. And I think that's a fair representation of the larger feelings of the working group as well. So at times I may speak as the director of OPR, and at sometimes I may speak as the facilitator of the working group. I'll try and be clear which perspective I'm speaking from. But telehealth is practice. Telehealth is crucial, but it is practice. And so this short-term recommendation, the temporary registration requirements, balances the fact that currently under Act 6, folks are providing telehealth without any notice to the state of Vermont. We do not know how many people are providing telehealth who are licensed in another state currently. There is no notice to the consumer how that person is licensed necessarily in a telehealth relationship. So we were contemplating all of those factors. The short-term recommendation is light touch. It's easy to stand up for both the Board of Medical Practice and OPR. That was candidly a big concern of, please don't have the short-term recommendation be bulky, because we're going to have to do it quickly. We're going to have to do it nimbly. So that short-term recommendation, temporary registration, very simple: name, contact information, and verification of licensure from other states or state or states. There should be a fee associated with this, or general fund allocation. This is work that state agencies are going to need to do. Both of our budgets are on special funds, siloed funds. If the work is not compensated in some way, then it falls on in-state licensees. So from our perspective, and I saw that David Hurley, he just joined, but from our perspective, there should either be a fee for the short-term recommendation, understanding that might slow things down. We would ask for a general fund allocation to support this work. I'm happy to speak to the importance to the general public to allow telehealth. And I'm sure that many others on the call would as well. This has really, not just in mental health, but in all areas of healthcare, this has really facilitated better patient care and better, still can't say it, better continuation of care for a patient as well. So continuity, that's how I say it. So better continuity of care. So it's really critical to the healthcare fabric and a patient's experience moving through the healthcare system. For the short-term recommendation, we are recommending that there's no patient limits and no length of practice, but that the registration does expire on June 30th of 2023. Moving into the long-term recommendation, we have a recommendation for a tiered system. First would be a registration, which would have a low fee or no fee, depending on how the funding allocation is. It would be for a term of not more than 120 consecutive days, and it would not be renewable. And it would be for folks who had fewer than 10 patients. Then there would be a telehealth license that would have a fee. It would be a term of 2 years. Someone could renew it, and it would be for someone who had up to 20 patients. And then there would be the full license or compact. And I should just put an asterisk there. The working group really does recommend compacts as part of a solution for telehealth, not the full solution, because it's not a viable option across all of the professions, but a full license or pursuing compacts should always be considered by the state of Vermont. For the long-term recommendation, it would be similar to the short-term recommendation with what would need to be provided to the state. It would, again, 120 days, and registrations could not be renewed. I think my slides are out of date. We made it so that you could only register every 3 years. My first slide said every 5, but it would be every 3 was the final recommendation. It would limit it so that it would only be for telehealth. So someone who's registered under this provision could not come in and set up a brick and mortar store or office without obtaining the full license. It would be limited to no more than 10 patients. Fees would be determined based on resources. Let me go down. The telehealth license would be for no more than 20 patients. It would be renewable every 2 years without any other restrictions. Again, only able to provide telehealth services. It would be, there could be profession-specific rules related to this that the like in terms of disclosures was a big issue, and of, if you're receiving telehealth, you're in perhaps in a more vulnerable position than if you're walking through the doors of an institution. So should you be told that service is being provided to you by telehealth, and this is where you could complain about the professional. Those were the types of things that we were contemplating as a working group. We want to make sure that those are done on a profession by profession basis. Specifically disclosures and maintenance, continuing education, but also what's required for obtaining the license. What do you have to show the state to get a telehealth license? And we are asking for the authority to issue those rules, both the authority for the Board of Medical Practice to do that and the authority for OPR to do that. We really conceptually would like the application process to be abbreviated and less administratively burdensome than applying for the full license, but it should be more comprehensive than a registration because you do have a wider scope of practice. The applicants should be licensed with the same or similar scope. So when you're coming as a mental health counselor, and you're providing telehealth in Vermont, you should have a similar scope of practice in your state of origin. you should be required to comply with state and federal laws, including protected health information or anything that's specific to Vermont. So for Vermont, we have some specific healthcare related laws that we would want to inform the telehealth licensee that they need to comply with, and then that we should expect that person to comply with. The disclosure, that would be determined profession by profession, but here's some of the things that we thought a disclosure would have: how to file a complaint with OPR or the Board of Medical Practice, information about resources in case of emergency or crisis. That was one concern, particularly in mental health, that, if you're receiving telehealth mental health care from someone in Kansas, will they know, or how do they help you find emergency care? And we want to make sure that the provider has the burden of informing themselves how to do that and helping that person through that scenario. Notice that the provider is only licensed to provide telehealth, the jurisdiction where the provider is licensed fully, and the requirement that the provider comply with Vermont laws. This is essentially consumer knowledge consent. I see that Representative Donahue's hand is up. I don't know if you want me to pause, Senator Lyons and Representative Lippert.
If, there may be questions of clarification. So Representative Donahue, go ahead.
Yeah, I'm happy to hold it if it's too much in depth, but I'm just wondering, those 5 seem to all be very important disclosures to patients. I'm wondering why you would recommend that be the individual profession that decide it rather than the board and OPR or the statute itself.
So the concept is that it would be that the profession, the regulatory board, would help craft those requirements with the assistance of, well, the Board of Medical Practice, it is the board, but with the assistance and oversight of OPR, and that it be done with a profession by profession specific lens. So for instance, what may be required for mental health would not be the same as it would be for optometrists. The requirements for an emergency or may be different, or the requirements for the application itself may be different.
Okay, thank you. I was misunderstood because of the language that they may be required as determined by the profession. So that's...
I'm sorry, it should probably say by the professional board or the advisors for the profession with the oversight of OPR. Not by the individual professional. That's the piece that really would need to be clear. It would be drafted and it would go through the administrative rule process of what's required. But there is the concept of these requirements not being baked into statute and us being allowed to do rulemaking around these requirements, obviously following the administrative rule process, but not adding the requirements for telehealth license in each profession in the statute. That is the ask of the working group, so that it's a bit more nimble. Okay, was there another question or?
Yes.
Go ahead, Representative Cordes.
Thank you. Using this recommended process, after a provider has attained telehealth licensure, what is the mechanism by which any out-of-state disciplinary action would, that information would make it to you or to the necessary regulators?
For some of our professions, Representative Cordes, we receive speed memos or emergency notifications of discipline. For some, we do not. And some of our sister states require that the licensee notify us immediately in the disciplinary order. Some of the states do not. What we typically find is in the renewal process, when we're asking has any state taken disciplinary action, we do learn that, let's say New Hampshire has taken disciplinary action against a physical therapist. For nursing in particular, we receive a memo anytime discipline is taken against any nurse that we license. So it is really not a problem in that profession. It's not a problem in osteopathic physicians. It's the professions with less robust associations of regulatory boards that we do have a delay in learning about discipline taken by a sister state. There is, we could have as a requirement that a telehealth license notify us of any discipline in another state. That could be either a profession specific requirement or a requirement on whole.
Join the meeting.
To make sure that we are learning about the discipline. I have to say that I think that for our full license group, which is what we have now, we learn about discipline fairly quickly and fairly efficiently, and we are able to move quickly to protect Vermonters when discipline is taken in another state.
Thank you. I think it would be good to, if we could help close any gaps, and I'm thinking in particular of any physical or sexual abuse that may not make it to us in a timely fashion.
Yes, I hear that concern.
All right, Senator Hardy has a question.
Thank you, Senator Lyons. Lauren, this is a basic question that I should have asked at the very beginning, and I was racking my brain for our conversations last year, but the definition of telehealth that you all used for your working group, does it include audio only telehealth, or is it just video telehealth?
It's telehealth by any means allowable in the state.
Okay, so it would include just the phone conversation visits as well?
Yes.
Okay, thanks.
Yes. So I referenced this earlier, a telehealth provider would still be subject to the same standards of care, the same scope requirements. So a telehealth provider would not be able to exceed the scope of an in-state, in-person provider. The Office of Professional Regulation or the Board of Medical Practice would have legal jurisdiction over that professional, meaning we could take the authority to practice away or restrict it. If there was supervision or collaboration requirements, that could be placed on the telehealth provider. And importantly, if there are requirements related to prescribing, that would be on the telehealth provider. And prescribing is where I fully anticipate there would be profession-specific guidance related to telehealth. Prescribing via telehealth may have more risks than prescribing in person. It may not, but there would be, we'd want to make sure that people understood the prescribing requirements in Vermont, particularly with our prescription monitoring program, and understood our controlled prescribing rules, if controls are allowed at all. And again, that would be something that would be done on a profession by profession basis, because it was just too broad an application to really address in this report. And we were going to get too far into the weeds of what should be done. That's really a conversation that needs to be done on a tighter, closer basis, which is why we're asking for authority to do rulemaking. Again, venue and oversight, this would mean that you'd have to agree to be subject to Vermont civil venue and state oversight and enforcement, and you should be required to carry malpractice insurance. Again, probably on a profession by profession basis. You know, if you're part of Dartmouth Hitchcock and you're providing telehealth to a Vermont patient, you know, you should be covered by Dartmouth Hitchcock's insurance provider. But if you're a solo practitioner with a mental health practice in New Hampshire, we want to make sure that Vermonters are protected from a civil remedy perspective. So we really want to encourage people to participate in healthcare sharing or record sharing. being, we don't want to break down our primary care, the primary care home. So we want to inform people how to provide information into that. And this also, there will be a burden on the Office of Professional Regulation and OPR to help people become familiar with in-state resources for referrals, emergencies, crisis care. This was really, a critical concern, was just, we don't want people to not have resources just because they're seeing a telehealth provider. There should be a fee. It should be less than a full licensure fee, most likely. And how that's done, I'm really excited to talk with Jen Carby about. I'm hoping that there's some creative ways that we can create that fee, whether it's 50% of the standard fee or 75% of the standard fee, so that we don't have to adjust that fee in addition to the full licensure fee every time we adjust the licensure fee. I don't even know if that's possible, but that's something I'd like to explore. And there should be an exemption from licensure requirements if there's consultation between an out-of-state provider and an in-state provider. This is not intended to interfere with what is standard practice of practitioners to consult and have a peer-to-peer second opinion. We want to make sure that that continues. Part of this recommendation, and it does dovetail with the Act 6 extension discussion, is provisional licenses. We would like, as an office, for OPR to be able to issue provisional licenses. This would be a permanent, not something that is expiring. So I didn't bring it up in the Act 6 discussion, but we would like to be able to issue provisional licenses. I know that the Board of Medical Practice is exploring this as well. But speaking as the director of OPR here, we would like to issue provisional licenses to people who have applications for full licensure, whose application is not able to be processed for 2 reasons, or for any member of the military or their spouses. So the 2 reasons are verification of licensure from another state. This is the core reason that our applications are delayed. If you're coming to Vermont from another state, you can submit your application any time of day or night. Our application is open 24 hours a day, 7 days a week, online. Our staff receives it. Our staff looks at it. I have the data on this. Our staff looks at it usually within 72 hours of it being submitted to our office. And that includes when it's submitted on the weekend. So our staff looks at it very quickly. Our staff processes that application very quickly, meaning looks at, what's required and have you answered the questions. But we frequently are waiting for verification from Nevada, from Connecticut, and from Kansas. And the application process is completely dependent on how Nevada, I forget what I said, Connecticut and Kansas, how fast they turn around those verifications. And that can take weeks. That can also take months. This is a core frustration for our licensee applicants, and it's across all fields, not just healthcare, but particularly right now, as we're trying to get people licensed as quickly as possible, and with a focus on healthcare, which has been the directive, is that we prioritize right now healthcare applications. So, if we have 500 applications that come in on a Monday, we look at the ones that are healthcare and we prioritize those healthcare applications. Being able to give a provisional in that scenario would really help. The other place is fingerprint supported criminal background checks. That introduces delay because that can take 4 to 6 weeks to get a criminal background check. And we'd like to be able to issue a provisional while we're waiting for that. This is critically important, particularly as we move into background checks being required for nursing applicants, which has not been required previously. As we've discussed through the nurse compact process, we've always asked people to attest to their criminal background, but part of the compact agreement was that we have background checks that are fingerprint supported. That is a new process. We're starting it in February. We are thinking that this will create delays. We want to avoid that if at all possible. So it would be the authority to issue provisionals for those two reasons. It would be voluntary, really, to expedite entry into the workforce, which means we'd ask the applicant to forego procedural rights associated with the conventional license in exchange for the provisional. What that means is if we find a problem, we'd like to be able to revoke it quickly. And then the remedy would be the conventional license application, because that would always be there. And we would ask for a robust attestation of the material facts, again, balancing speed with public protection. And we'd like the authority to extend it if necessary beyond the 90 days if the verification from California has not come in, which I can tell you the verification from California will not have come in. They're in the 6-month wait list for some of their professions.
Madam Chair, can I ask a clarifying question about this issue? You're muted, so I'm going to assume you said yes. Okay. Thank you, Lauren. You mentioned compacts. Does the light nurse compact and other compacts allow for provisional licenses?
No, the nurse licensure compact and the physician compact do not allow for provisional licenses. But what we would do is if there was someone who had applied for a compact license and they, let's say, use the nursing license as an example, they applied for a nurse compact license and we wanted to issue a provisional, we would just issue a single state provisional license, so that we would only be authorizing their authority to practice in Vermont, not in any other state, until we issued the compact license. Okay. So I don't think this will interfere with the nurse licensure compact process.
Okay, great. And then my second question is the definition of military member or spouse. Would that include Vermont National Guard members or just active federal?
I'm open to it including the National Guard. I think the proposed language is armed services, and I have to admit I don't know whether that includes the National Guard.
Okay, I don't know either, but just wondered all right, thank you.
Yes.
Okay, before I call on the next person, I'm going to ask, can we have these slides on our webpage? And I think it would be helpful for you, Lauren, to take your slides down unless someone else in your group wants to speak to them.
I don't think anybody else is planning to speak to them, so I'll stop sharing.
All right, that's good. Now we can see. Aha. So Representative Goldman and then Representative Page.
Thank you, Madam Chair, and thank you very much, Lauren. I have two questions. This one's simple, but when you look at provisional license, and I know you're waiting months and months, do you get a copy of the license so that you know the person does have a license, at least to start that file?
So what we would do is we would ask for the license number and an attestation from that person that the license is active and in good standing. We have talked about operationally whether we could have someone submit a copy of the license, but we have had fraud there. It's easy to manipulate copies. And then we've also talked about whether our staff could manually look up on other states the status of the license. And we may do that, but we would like the statute to not require that, because not every state has an online licensee lookup, and some states don't update their online licensee lookup on a routine basis. So it may not be as reliable as we'd like it to be, and it may create administrative burden to do.
Yeah, I totally see that. From the protection point of view, I just worry about that gap and how, and I know you're thinking about that. So thank you for that.
You're welcome. And that's my key concern with all of these, with all the telehealth, is just public protection, with my regulator hat balanced with access. And with the provisional specifically, that's why we would want the authority to immediately revoke it without any due process if there's a problem, because due process, back to constitutional law, if you have something, then you have a due process right, and it can't be taken away from you without some process, and a license is that. And what that means is when we receive a complaint that's concerning about a full license, it takes time for us to investigate it so that we can prosecute it appropriately. We have to have a hearing where the person could be represented, as they should be, and it's before a tribunal. What we don't want is to recreate that process for the provisional. We want to be able to take it quickly if there's a problem, and then have the regular application take its course and have the due process attached to that traditional conventional license.
Thank you. Madam Chair, may I ask a second question?
Yes, please go ahead.
So could you help me understand the issue of how registrations may not be renewed? I'm not sure I understand sort of the thinking behind that.
Sure. So the goal of the working group was that first, that full licensure is the preferred model. And, in full disclosure, the limitations on patient limits and renewal is geared towards, we as a state should prefer folks to be fully licensed. We understand that telehealth licenses are a good idea, and the working group, I forget if I mentioned this, but the working group looked at other state models for how other states are handling telehealth. And the concept of a telehealth license or a telehealth registration is not prevalent, but certainly prominent. And what the telehealth registration is, it's someone who's casually thinking about doing some telehealth. They may only have one patient that they're following to college. I'm a mental health provider in Connecticut. I've seen a high school student who's now coming to UVM. I just want to continue with that one person for a period of time until they get settled with a new provider in state. That's the telehealth registration. The telehealth, both short-term, the short-term has no requirements at all, because it's supposed to be the gap between Act 6 and the final recommendations. So the long-term registration has those limitations. Then if you are, the Connecticut mental health provider, and you find yourself that you are seeing 10 people, your town is sending all of its students to UVM, and you have 12 students attending UVM, and you want to see them for the whole time that they're there, then the telehealth license, the acknowledgement is that you have a more significant presence here. The state should have more information about you. You should be more integrated into the fabric of Vermont's healthcare system, and you should have a telehealth license, as opposed to that interim, I'm following a patient for a short period of time.
Yeah, I totally get that. I think anecdotally, I could see a student coming, having a relationship with their therapist in Connecticut. Time goes by, they're doing okay. Then they need a tune-up. I mean, that sort of happened to all of us, and not to have to start again. So that was what I was wondering about, sort of a renewal of a registration to fill that. That's what I was thinking about.
And I think what the working group would say was that person should get a telehealth license. They're planning to have a more ongoing relationship with that patient. And that is a balance that we should discuss in terms of fee and application requirements. So it's not a burden to get that telehealth license. That's the goal. It wouldn't be a burden to get that telehealth license. It's just by continuing your relationship with that patient, you're more integrated into the Vermont healthcare system than that temporary basis.
Yeah, I totally get that. Makes total sense. So you're moving from this short-term to a long-term relationship. Thank you.
Exactly.
Okay. Representative Page.
Yes, I was curious about what the licensing fees are, and are they equivalent to surrounding states in Vermont or elsewhere. And then finally, in the compliance of your federal laws and state laws, are there requirements of the provider related to taxation of income? I know I'm getting out of the health questions here, but this is more of a
Wait,
money.
you do have the chair of finance sitting in on this, so.
Oh, okay, well,
might
that's
be
great.
helpful.
Thank you. I was just curious, the taxation of income that's from somebody that's in Vermont and yet practicing outside of the state of Vermont. Does that make, am I being clear?
You are being very clear. I have to say, we didn't talk about taxation at all. We talked about every topic except for taxation. So, and we didn't talk about every topic, but we talked about many topics, but we never touched on taxation. And I would be so far in over my head if I opined about it. So.
I'd be very curious to find out how you would tax, that provider in making money from a patient that's in Vermont. So anyway,
so you know what, Senator Cummings may be able to shine a light on this.
I'm not sure. This is new. If you're working remotely and you're physically in Vermont, there's some waiver and forgiveness,
Right.
but technically you pay Vermont income tax on what you earn while you are physically located in Vermont. I have a feeling this is new. This is more like buying over the internet. You're not physically, your patient is in Vermont. So the tax commissioners coming in, this will be a good question to ask, especially if it's could be getting up there in numbers. But I have a feeling it's a gray area.
Thank you for the clarity, Senator Cummings.
Always willing to help.
And what were the fees? Do you have any idea on the fees?
I do. I have a very concrete idea on the fees, but I can't recite them all because we have 163 different profession types. I think 80 of them are healthcare related. So fees are specific to each profession type. Our funds are siloed. We adjust fees when we're allowed to and when we need to. So we look at the fund on whole and we look at it profession by profession. So we look at the nursing fund separately from the chiropractic fund. We also have some professions that are advisors and those fees are pooled. And then our professions fees compared to other states, it depends. Some of our professions are far cheaper than other states and some are more expensive. And those are conversations that always come up whenever we're adjusting fees. And I know that was really not a good answer, but I don't know how to get into it beyond that.
But you know what?
I would just say that Ways and Means Committee weighs in on these issues of fees.
And finance.
And finance.
Yeah, but I mean, in the House, Ways and Means, and in the
House
Senate,
and
finance.
Senate.
Yeah.
So before I turn to Representative Peterson with his question, I do have a couple of questions, and we got sort of into the money area. So you don't have to answer this right now, but going forward, as we're looking to make some legislative recommendations, what costs do you anticipate for the registration? And then there's also record keeping associated with this. So have you looked at costs and what ballpark are they in? And then the other one is there any ARPA money for this? Because so much of telehealth is so directly related to the pandemic. And it would seem to me that establishing and setting up initial setup for registration or whatever regulation might come out of an ARPA donation. So that's my second question. And then I have a third question, and you might forget it going ahead, but I noticed that VPQHC was there, and you're going to have a database system, and will you be segregating any telehealth quality data and able to evaluate that? Will VPQHC be able to do that? That's maybe a way out there question at this point.
So yes, is the answer to ARPA. Please designate some ARPA funds to the initial setup of this program. I would please do that. We have started to think about, you know, the IT system changes, the operational changes. Obviously, you'd want to hear from David Herlihy as well. You know, I think the amount of that initial setup cost would be dependent on whether or not you attached a fee to the short-term registration and what the fees would be on the ongoing basis for the long-term registration and the long-term telehealth license. I do think it makes sense to support this, for the General Assembly to support this from the general fund for the initial setup. I want to be careful that we're not putting the cost of this program onto our in-state licensees, which without fees or without a general fund allocation, our in-state licenses would be paying for the operational setup of telehealth licenses for out-of-state licensees. And this was a tension that the working group talked about a lot.
Okay.
Definitely something that David Herlihy and I have talked about a lot. So I don't have a final number for you right now. I don't think you're asking me for that, Senator Lyons, but I don't have that number. But I think it depends a little bit on the fees for the actual registration, short-term or long-term or license. But there is some startup costs, and I think we could all make the argument that ARPA is appropriate. Data from these folks, we would be able to give that data to everybody who asked. We could gather the same data that we request on an initial license. You know, we have surveys that go, you know, there's mandated surveys that are done for every healthcare licensee in the state. We could have those requirements built into the telehealth registration or license application.
And so you're thinking that, it seems to me that a lot of that information would be embedded in the rules that you're asking for, the rulemaking process.
Yes, although a lot of, you know, I'm blanking on the organization that that we have our licensees fill. It's with, oh, I'm embarrassed. It's with the, it's UVM. They gather data on our nurses, and they ask a whole lot of demographic information. They ask a lot of employment information. Those requirements could still be on a telehealth license for a nurse. And I don't know if that would need to be in rule. Quite frankly, the requirements that a nurse fills out that survey now is not required in OPR's rules or statutes.
Okay. Yeah, thank you. There's a lot here, and there's certainly a lot of work embedded in what you've presented. And some of it will be asking for your recommendations, in particular on how much. And then finance, ways and means, appropriations folks are going to have to help us out with this as well. So we want to get it right. And I completely agree with the concept of having ARPA funds for the startup, the fit up. So we've got a lot of questions here.
Before I'm going to, just as a co-chair here, jump in, and Senator Lyons, I'm looking at our time, and we have witnesses waiting, and we have a lot of questions, and I think we just want to think about how we best proceed to be able to hear the rest of our witnesses. We're clearly not going to be able to achieve that in the next 5 minutes, and so
No.
So
My question was for Lauren in the beginning. Are all these folks expecting to testify? I thought you were representing the group, so maybe that was your answer. Went in one ear and out the other.
I think I'm representing the group, but they may have additional factors to add. I don't know.
Okay. maybe I
Okay,
misunderstood.
I thank you, Representative Lippert. So those of you with your hands up, you may have to hold your questions for another time. So Devin Green, you have your hand up.
Yes, do you want me to hold?
No, go ahead.
Oh, great.
You're the witness. We need,
Devin Green, Vermont Association of Hospitals and Health Systems. As I'm hearing about the process going forward, so I would say that we do support these recommendations. We've been a part of the process. I just want to stress, when I hear the process going forward, we do need to make sure that we incorporate the sort of near-term recommendation of having a registration process until 2023, just because our hospitals are extremely stressed right now. We have the highest need for critical workforce in the nation for this week. That was reported to HHS. We have people who are our emergency departments are having to treat people that they don't normally treat, who would normally go to tertiary care. And part of what we're doing with that is bringing in a telecritical care organization that is part of the Army's telehealth branch to help support those folks as we come up on Omicron. So I would just like to make sure that that process is as smoothed out as possible with as little interruption as possible. So maybe if you are going to want a more extended process for the rest of it, if you could break off the piece that says we'll be okay until 2023 and maybe place that in the Act 6 portion, that would be really helpful.
thank you. All right. Meredith Roberts, who else in the group? Jessa, Rebecca Copans, David Hurley, Meredith Roberts are all here.
David just said in the chat he has to leave.
All right. We will hear from all these folks
Yes.
additionally, but Meredith, did you have your hand up?
I just have a very quick share for the record. I'm Meredith Roberts, the Executive Director of the American Nursing Association, Vermont. And you have my statement online. I'm not going to read that to you. And you know that the college students are already expressing fear about their current out-of-state mental health providers. Their services may be affected. So we need to do this very expediently. And I was in 4 of the 5 subgroups. And so I just want people to know that our American Nursing Association of Vermont supports the need for providers to initially obtain that temporary registration in the tiered approach by the 2023. And while nurses and physicians have compacts that ensure the health professional providing services is credentialed and has an unencumbered license in the majority of states, not all health professions do. We need to make sure that there is safe practice. And even in the nursing profession, not every state belongs to the compact. So a plan for those states is needed. The rules for practice can vary between states, such as the ability to independently practice and prescribe. And to Representative Peterson's earlier point, the need for malpractice insurance was also discussed, and there was much discussion on the scope of practice and prescribing. And having that initial step of registration will allow for uninterrupted provider service and access to care for patients. The impact on the nurse compact was very carefully considered. And I even had American Nursing Association at the national level review the work group plan that Laura put together. She did a wonderful job leading, and their legal counsel did not detect any concerns. The work group worked very hard and thoughtfully together to ensure that stakeholders' voices were heard and input received from nurse practitioners, as well as registered nurses and other stakeholder groups, collaborating to achieve this plan that would minimize the barriers to healthcare, to telehealth, yet keep Vermonters safe. And the plan ensures that out-of-state telehealth providers comply with Vermont's standard of care for the profession and attempts to minimize barriers to access of care. And that's all. I'm available for questions, and thank you for allowing me to testify.
Thank you.
Thank you.
Thank you. And thanks for your good work. David had to leave. We will get him back into our committees. Jessa or Rebecca, Jessa Barnard, Rebecca Copans, I'm gonna look to you first. You're there.
Hi, Senator.
Hi.
How are
All
you?
right.
Oh, good to see you. Rebecca Copans, Blue Cross and Blue Shield of Vermont. I want to just really thank Lauren and her team for their process that allowed this issue to be looked at from literally every side. They offered an opportunity for all stakeholders to weigh in on this issue at extreme depth. And universally, the group agreed that continuing to allow a full waiver of license doesn't offer the protections that Vermonters deserve. And mandating provider registration and creating a path for a streamlined, tax limited approach that supports access to and continuity of care, ensuring that if all providers practicing in Vermont is for the long term will pursue licensure, we feel this is the best approach to balancing access and protection.
Yeah, I'm saying that the connection with Rebecca Copans is intermittent. So I think some members and myself we're only hearing every fifth word or every other word or something. And now I'm hearing nothing.
She's on in 2 locations, I see.
Rebecca, if you disconnect your phone, it might help.
No, we can't hear you. You know what, Rebecca, we'll get you back in. We appreciate the work that you've done on this, and I know Blue Cross and Blue Shield has been a major participant in a lot of this work. We gotta have, it's really important to have technical difficulties, then we know where we need to fix our gaps.
Especially when we're talking about telehealth.
I know Senator Cummings is working on it. Jessa Barnard, did you want to add?
Jessa Barnard with the Vermont Medical Society. I can keep this to under a minute, I think. I just want to say that we appreciate participating in the process. We support these recommendations and the tiered approach, as everybody's mentioned. I would like to refer people, I think it really does relate to the earlier Act 6 conversation about why not just make some of these complete waivers permanent. The subtleties of these sorts of issues and why so much thought went into this process. And I think pages 16 and 17 of the report go through a very thorough discussion of sort of why not just waiver? Why do we need these protections? Why do we need a tiered kind of subtle approach? So we fully support that. And being more nuanced, and we fully support especially rulemaking for profession by profession distinctions. You know, Lauren mentioned the differences between optometrists and I forget the other example, maybe it was nurses, but you know, we heard from veterinarians, you know, well, what about veterinary medicine practice? And probably things related to disclosures and malpractice insurance would look very different. And who are we even considering sort of the range of healthcare professionals who this would apply to? So I think we need some to be able to be specific to different professions while putting in place a broader framework that applies across the board. So we really appreciate your attention to this issue. We fully support what Devin mentioned, which is please don't leave a cliff in March. So at least put into place the short-term step while we're working on building the permanent steps. If possible, we'd love to see all of the framework that's in the Act 21 report move forward really as soon as possible, but especially the short-term pieces. So thank you so much. And we're happy to be part of the process moving forward.
Thank you. So you each who have provided testimony today, and some of you probably have a lot more to say, we'll keep working together on both Act 6 and telemedicine, and we'll have you back in to complete our listening process. So thank you all. Thank you all for your work. I greatly appreciate it. And I just got a notice from Rebecca Copans. We're good. Yes, we do have another. I have 2 meetings in the. We all have meetings coming up.
Right.
So I think what we'll do is we'll end for today with great appreciation for all the intense work. And this is the beginning, and we will be putting this back on our respective agendae. And
Yes.
thank you all. Bill.
Yeah. Yeah, just thank you all. And occasionally people say, well, the legislature just creates study groups. I think this is an excellent example of asking a group to come together, bring your professional expertise together on our behalf. And this has been terrific. Thank you, Lauren, for facilitating the group and others for their deep participation. So we will, Senator Lyons and I will make
Caucus.
decisions about how to move forward from here.
It's
Thank
really been an honor, so thank you.